Good afternoon, everybody. Thank you all for being here on a Saturday afternoon to listen to me, and that's a hard case to follow. But thank you again for being here, and I look forward to the discussion. So my name is Matthew DiCosta. I'm now a renal transplant fellow, but I was a first-year nephrology fellow when I submitted this case. And so I'm very thankful for the opportunity to be here, and really thank the Hypertension Committee for inviting me to be here, as well as the excellent mentoring that I received from Dr. Schwartz and Dr. Taylor in this case. So I'd like to present this case kind of like how we met the patient. So I know we had a different title in the program, but we wanted to kind of present the case as how I met the patient. So he was essentially a case of uncontrolled hypertension in an elderly man on multiple antihypertensive drugs. And I have nothing to disclose. And so I'd like to summarize the case as follows. So we have an 80-year-old gentleman. He's a retired family medicine physician, and as a first-year nephrology fellow, and I know some other people in the room might get a little nervous when you're treating physicians for hypertension. He was a non-smoker. He's non-diabetic. And he had a past medical history of hypertension for 25 years, and I'll get into the details of that in the next couple slides. Coronary artery disease, status post-stenting, 2 years prior to presentation. A bioprosthetic aortic valve replacement for aortic stenosis. Paroxysmal AFib with a history of TIA, CLL on ibrutinib, and I'll talk more about what ibrutinib is later, benign prostatic hypertrophy, or BPH, hyperlipidemia, and what was thought at the time as mild chronic kidney disease, stage 3, with a baseline creatinine of 1.3. So regarding his hypertension history, it was previously well controlled on monotherapy with atenolol and then subsequently amlodipine prior to presentation. However, he then developed an acute kidney injury with a peak creatinine of 2.5 in the setting of sepsis due to aspergillosis, and his amlodipine was, of course, stopped during that episode. His kidney function eventually did recover with the creatinine again of 1.3, but due to the aspergillosis, he was placed on lifelong posaconazole prophylaxis, and we'll talk about the significance of that later. Over the next 2 years and up until presentation, when we met the patient in clinic, his blood pressure control became suboptimal, with home and clinic readings ranging from the low end 130 systolic up to the 180s and sometimes even higher, with diastolic blood pressure still reasonably well controlled in the 60s, the 80s. And when he'd have those higher blood pressure readings, he did complain of headaches when those occurred. So he was followed by his cardiologist with this prior cardiac history, and he was initiated and treated with an increasing drug regimen. So previous to that, as I mentioned, he had been off amlodipine, and then when his blood pressure became uncontrolled over these 2 years, losartan and then metoprolol was started, given his cardiac history. He was then started on hydrochlorothiazide. Subsequently, amlodipine was added at a small dose. And then finally, he was noted in clinic over multiple office visits to have edema, so he was prescribed furosemide 40 milligrams weekly for that. And then just on his physical exam, I'd like to review his blood pressures when we met him with a BP True device. Their blood pressures were elevated at the 144/77. A standing blood pressure was still elevated at 142/74. His heart rate was reasonably low at 62. His BMI was 28 with a weight of nearly 74 kilograms, which had been stable over these previous 2 years. So his weight really hadn't changed. On exam, he was alert. He appeared younger than stated age. He had a benign fundoscopy. His cardiac exam was essentially normal, although I did note the prior aortic valve replacement and associated murmur with that as well. And he also had a significant amount of pitting edema, as previously noted. His lungs were clear, except for chronic changes in the right lung base from the prior pneumonia related to aspergillosis. His abdomen was soft with no bruits or masses or organic megaly, and his extremities had equal pulses peripherally. Of note, within his history of CLL, he also did have evidence of lymphadenopathy as well, and especially in his upper extremities. So just to kind of take a step back, so what is your initial thoughts and considerations in this patient and his uncontrolled hypertension? Looking for any additional questions or thoughts you guys might have early on. I have a lot of work upcoming, don't worry. So, yeah.
Are there any comments in terms of the uncontrolled hypertension? And if I just recall, this has been in the previous 2 years, is that correct?
Yes.
That things started to become
uncontrolled.
And during this time, was he given any other medication other than the change in antihypertensives?
No, that was it. So and we'll talk about that later, but the main agents, other than the antihypertensives, were the posaconazole, which he was on for prophylaxis for aspergillus, as well as the ibrutinib for CLL, which he had been on for 5 years up until when I met him. So,
So the definition of resistant hypertension requires optimal dosing, which means maximal or maximally tolerated dosing. And I think this gentleman was undertreated for the hypertension, at least as it's presented up to this time. And in addition to that, it would have been nice to use chlorthalidone or indapamide instead of hydrochlorothiazide in this regimen.
Agreed. Yes, that's a favorite of mine too. And so I'll get to that. Actually, that's a nice segue into my next slide. So what is the definition of resistant hypertension? Does this patient actually meet the definition of resistant hypertension? So we do have a failure to reach blood pressure goal, at least in the clinic, and I'll get into more readings coming up. And again, there's a concurrent use of at least 3 drugs, including a diuretic. However, as Dr. Carey nicely pointed out, that the patient really needs to be on optimal doses of these drugs, and he was on low doses of some of them. And you could argue, yes, he's beta blocked, his heart rate's in the 60s, but he could be on a higher dose of losartan. He could be on chlorthalidone instead. He could be on a higher dose of amlodipine. So really, he wasn't on optimal doses of these drugs. And so therefore, he really didn't meet the definition of a resistant hypertension. But you can at least use these thoughts to kind of give you an idea of where is this patient's status at in terms of his hypertension, and use the definition of resistant hypertension to kind of trigger your thoughts and how to work up this patient and manage this patient. I also want to point out too, adherence to therapy. The patient has to demonstrate that they're adherent to therapy and have all of these other bullet points met in order to meet the definition of hypertension. And so we wanted to go through a checklist, and I'm sure many of you were at Dr. Flack's talk this morning. I thought it was excellent, actually, that talked about resistant hypertension and on how to approach those patients. And we'll address many of those today, so I won't belabor many of the points from his talk. But I want to go through and ask mainly just the questions when you see a patient with uncontrolled hypertension. So the first question you should always ask is, this patient was on many drugs that were antihypertensives, but was he actually adherent to his therapy? You would think that as a family medicine physician he would be, but you always have to ask, right? Are his office blood pressure measures correct, right? He could have, even though he is a physician, could he also have white coat hypertension as well? Maybe less likely with the BP True device, but we still need some more data from the ambulatory setting. Is there an associated condition present? So does he have pain that's causing his hypertension, as previously stated in the case before me? Does he have obesity? Well, he really doesn't. He's mildly overweight. Does he have sleep apnea? Is there any identifiable cause of the hypertension? Does he have significant renal disease with the data I gave you? Probably not. Does he have any other associated conditions that would cause it? One of the things that wasn't there wasn't much detail mentioned about in the earlier talk I mentioned today was about interfering substances. Is the patient taking drugs that may be affecting his blood pressure? And we'll get into that later. And then the last two questions are, is his extracellular volume controlled? Given his edema, you can argue maybe it's not. And then finally, is his drug program appropriate? And then we've already had some comments that maybe it might not be the most appropriate drug regimen. So we're going to structure our talk based on these. So let's talk about adherence. So as a first-year nephrology fellow, you start to be a little nervous, but I was like, yeah, are you taking your medications? And so so he was prescribed this hydrochlorothiazide, and I apologize for the spelling error there, but he said, no, I'm actually not taking that. He was given furosemide about a week or two later for the edema, and so he thought that actually replaced the hydrochlorothiazide because he knows that's also a diuretic. So he thought that was replacing the hydrochlorothiazide. Then I asked him, are you taking your amlodipine? And he said, well, not really, because I only want to take it when my blood pressure is really high, because he knows that the amlodipine actually interacts with one of the other medications he takes, which I'll discuss later. So he was only taking it maybe once a week. And although when he did take it, he did note a significant blood pressure response. How about, is he measuring his blood pressure at home? He does check his blood pressure 3 times a day. He uses an excellent automated device at home. Also, his wife is a practicing nurse at our local hospital, and she also checks his blood pressure manually just to make sure that the readings are accurate. So we also wanted to see, okay, are these office blood pressures correct? So we had him undergo a 24-hour ambulatory monitor. Just to orient you, we have the manual blood pressures done by our blood pressure tech, who is very good at measuring blood pressures, much better than myself. And you can see that he had borderline elevated blood pressures when he presented. However, when he's wearing the 24-hour ambulatory monitor, you can see throughout the day that his blood pressures were quite elevated, several readings greater than 140/90. And then when he sleeps, you can see there was some dipping. However, he did have several readings that were elevated as well. And then he did have an episode of headache the following morning when his blood pressures were elevated. Yeah, please, yeah.
Did you do that?
Can you come to the microphone?
Yes.
We're filming.
I'm by the way, I'm happy for other people to come up here, but this is what I do now. And
Right. Yeah.
did you directly give him first the regimen?
Sure.
I think losartan
Yeah.
once a day is not as effective, especially at 100 as 50 BID. Amlodipine, HCTZ with a creatinine of 1.3. You didn't tell us his GFR. He's got edema. I'm very concerned about his edema.
Right.
Seems out of proportion for 2.5 of amlodipine. Is he on the imbrutinib? He
Yes, he is, yeah.
Okay. So I would have given, even though I didn't like his regimen, he was taking them all in the morning, and I would have, with this available, I would have directly supervised, my nurse would have, but I don't mind doing it myself, giving them the medication, and then placing the 24-hour ABPM on there. I think it's a more valuable test on the current therapy than just doing it, because that is telling you, oh, he's got a problem. And it looks like it's sustained hypertension with no particular pattern. But
Right.
I think directly observed therapy for the new definition, and you are showing 2008 Calhoun slides. Dr. Carey has a nice paper, which if you write this up, we should include that reference.
Yeah.
Directly observed therapy, I think, is key, even before primary care physicians refer these patients, because we have to rule out non-adherence. And we love our patients, they're good people, but they don't take their medicine.
Maybe I could just make a comment.
Yeah.
Yeah.
In our hypertension clinic, when we do have a patient with resistant hypertension
Mike.
who is on multiple medications, and it seems pretty obvious to us he or she isn't taking the medicines. We do have a protocol where we actually do a 48-hour ambulatory monitor. In the first 24 hours, they take their medications. In the second 24-hour, the medication taking is witnessed. So we actually have it before and after in one sweep. I must say, with some of the patients we see that you see like this, who are on unbelievable regimens if they're actually taking their medications. It's a little scary to have them take 7 or 8 antihypertensives in full doses in the morning in one fell swoop. And we've gotten into trouble, and we've had ambulance trips when we've done that, and they went into shock. So we actually give some thought to that, and we may not actually give them their full dose. We may give them half of that full dose in the morning. We've had to sort of work with that because it's unbelievable how often these people aren't taking anything.
And that's why I wouldn't let them come to the office without someone that drove them.
Okay. Let's move on.
All right, thank you for that. I agree. So this is just, in this box is just kind of highlighting the blood pressures, but this slide kind of summarizes them, okay? So his active systolic blood pressures were in the almost 160 range, and so his average blood pressure readings during the day were 159/80. And then even at night, while he did have some lower readings, his overall averages were still quite high at 152/75. And you can see that the vast majority of his readings were much above guidelines. And so we also wanted to do some workup. So there's a mention of, is there, what is his GFR, right? We're nephrologists, okay? We should look at that. So his renal function, as we mentioned, his creatinine was 1.3 milligrams per deciliter. So if you use the standard equation, MDRD, his eGFR was 52. So that sounds pretty good. But given that this gentleman is 80 years old, he's been through a lot, he has a lot of comorbidities, it makes you wonder if his GFR is actually less than that. So we do use other markers of GFR. In this case, we used a cystatin C, which is not dependent on muscle mass, right? So this gentleman, again, he's been through a lot. He's had multiple comorbidities. He has decreased muscle mass. So the cystatin C in this gentleman was elevated and actually predicted a cystatin C GFR of 27, so much lower than what his creatinine predicted. But in general, though, it's better if you have more numbers. And so we used GFR by CKD epi and using both creatinine and cystatin C. And this is a 2012 equation, and his GFR is 36. So either way, his previous GFR that was reported was more of like a stage 3A chronic kidney disease, but in fact, you could argue he has stage 3B to stage 4 chronic kidney disease. However, despite his advanced chronic kidney disease and his hypertension, he did have normal electrolytes. I don't have them here, but just to go in over several readings over several years, his sodiums have all been normal, his potassium's all been normal, and he had no metabolic acidosis or alkalosis. Again, we like urine as nephrologists, okay, so you want to look at the urine. And he had absolutely no urine sediment and normal and no proteinuria. Now you can argue, again, this is on losartan, but again, he did not have any proteinuria either, which is encouraging. We did assess his renal parenchyma, so we did have a renal artery Doppler study, which assessed the renal structures, and he did have some mildly echogenic kidneys, which is consistent with chronic kidney disease. He did have some simple cysts, but the kidney size is acceptable. He did not have any renal artery stenosis. We also assessed renin and aldosterone levels. Does this patient, we don't really suspect hyperaldosteronism, but we do want to assess whether or not, is he volume expanded? Probably. On exam he was, and actually renin and aldosterone was a good measure of that, and that these were both suppressed. We also looked for secondary causes with his exam, and his wife's a nurse, so she's also a very helpful resource for this, and she reports that he's not concerned about sleep apnea. She's seen many cases in the past, and she's not ever seen him have prolonged snoring episodes or have apneic spells. And so we kind of went through that, and so we're concerned about his volume, right? He has uncontrolled hypertension, we're concerned about his adherence, and we're concerned about his drug regimen, right? But what about the other drugs that he takes, and is there any other interfering substances? So he knows that NSAIDs are not good for him, so he's not been taking those. He does not take any other over-the-counter medications or herbal supplements. He maintains a low-salt diet, although he does like to eat out on occasion. And he does drink less than 3 drinks per week, and this has been very stable throughout his lifetime. So I wanted to bring in the discussion today. So I saw some people shake their head yes when I mentioned posaconazole. So I was wondering, what are you guys' thoughts on the posaconazole for this patient? We'll talk more about that later, but he obviously needs that. We don't want him to have aspergillosis again. So what are the thoughts regarding posaconazole and possible contribution to his hypertension? Yeah.
I don't know about this specific medication, but azoles in general have strong microsomal induction capacity, so they can affect variety of other drugs and also potentially endogenous metabolism of an endogenous substances. I don't know. I can't say at this point which one, but I think this is a possibility. I would like to have a comment about
please.
the previous workup.
Yeah.
I think in someone with low renin and poor response to losartan, seeking renal artery stenosis is a futile maneuver.
Correct. Yeah.
So a couple of comments about the posaconazole. So as you know, this is something that's associated with low renin and low aldosterone, and so it could mimic that scenario.
Right.
A couple of the factors that spoke a little bit against that was the lack of hypokalemia and metabolic alkalosis. You didn't show a chemistry panel, but I'm assuming that he didn't have that.
Right.
Although he had two factors that might protect him from hypokalemia, both his depressed GFR and his low sartan. Right. So that's a possible reason why posaconazole may still be involved, but you're not seeing the metabolic abnormalities that are classically associated with that. Otherwise, the posaconazole level in the studies that have been done so far on it usually point to the level of posaconazole as being a high risk factor. So this patient, I don't know when he was put on posaconazole, but the newer formulation by Merck that came out in about 2014, 2015 has a higher bioavailability. And so this has been reported much more recently because of that higher bioavailability. Right. So if he was put on this prior to 2015, I would imagine it is unlikely to be related to blood pressure and much more likely if it was more recent. But the dose would matter and the level would matter to make that call.
All right, very good. Yeah, and so I'll get into that exactly. Yeah, and this as an aside, we got the renal ultrasound not for the low renin, but to work up his chronic kidney disease. But yes, yeah.
Yeah, most of my questions were already addressed, but could you comment on kind of the interaction of the azoles with the mineralocorticoid receptor and then the different...
exactly, that's on the next slide. Great,
Yeah, my comment is not related to posaconazole,
totally
but
fine.
I'm concerned about ibrutinib.
Yeah.
It has been reported to
Let's
increase the
talk
blood
about it.
pressure
Yes.
in 40% of the patients.
Okay, I think we should move
Yes,
on in the
good.
interest of time.
You guys are giving my talk for me, which is great. So, all right. So, how about posaconazole and hypertension? So, as a review, posaconazole is used to treat invasive fungal infections and immunocompromised hosts. So, mainly in this patient with CLL on a chemotherapeutic agent, he developed aspergillosis. Actually in 2015, so that's when he was placed on posaconazole. And so again, so it actually induces a syndrome essentially of mineralocorticoid excess. It does this by inhibiting 11-beta hydroxylase, so leading to an accumulation of the mineralocorticoid hormone 11-deoxycorticosterone. So again, as we mentioned, while he had suppressed renin and low aldosterone, which would be a signs of a mineralocorticoid excess. He did not have the classic metabolic abnormalities, but again, he might have had protective factors against those. So that was one interesting aspect of his case. So could it be contributing to his hypertension? It certainly could be. But what about drug interactions? So what was mentioned before is that posaconazole is a strong CYP3A4 inhibitor. So what this does is can actually greatly increased the levels of amlodipine in the blood. And so, and also alpha blockers actually, such even tamsulosin. And so that was actually what the patient alluded to previously, why he was not taking his amlodipine. He did a literature search and saw that, oh, this can really make amlodipine very potent, so that's why I don't want to take it unless my blood pressure is very high. So that actually was playing a role in his hypertension as well. So what was mentioned was about ibrutinib. Yes, so ibrutinib is, just as a background, ibrutinib is Bruton's tyrosine kinase inhibitor, which is also known as A-gamma-globulinemia tyrosine kinase. It's actually originally identified in patients with X-linked A-gamma-globulinemia, and it's predominantly expressed in B lymphocytes, but also expressed in other cells, such as macrophages. And via its multiple mechanisms, it's involved in cell receptor signaling, B-cell proliferation and survival, differentiation, and their motility, as well as cytokine production and angiogenesis. So what was previously mentioned, what about ibrutinib and hypertension? So actually, ibrutinib is commonly associated with cardiac side effects. So it's been seen to cause or exacerbate atrial fibrillation. It is associated with increasing hypertension and edema as well. In these patients, hypertension can increase while they're on ibrutinib with new onset hypertension ranging from 5 to 14% in the first 1 to 2 years of therapy and up to almost a third of patients at 5 years of follow-up. Risk factors for this, which are also risk factors of hypertension, include older age, male sex, and potentially duration of drug administration. Now, the mechanisms why they cause hypertension, they're not entirely clear. They could be due to renal injury. My colleague, Dr. Manahar, published a case series of 2 patients that developed increasing creatinine on ibrutinib, and with biopsy proven essentially tubular injury and fibrosis. And so that was one hypothesis. Another hypothesis is that, as I mentioned, Bruton tyrosine kinase is also present in macrophages, which then can secrete nitric oxide. And so if you inhibit that, you might have decreased nitric oxide secretion, and that would therefore lead to less vasodilation and more hypertension. But yeah, there's still a lot of unanswered questions as to why, but hypertension is a well-known side effect of ibrutinib. So we've talked about the interfering substances. So it's definitely a possibility that they're playing a role in this gentleman's now uncontrolled hypertension that had been controlled for over 20 years prior to presentation. Now, what about this patient's volume status? So as previously alluded to, he has a lot of edema. Now, is that due to his chronic kidney disease? Is that because of his ibrutinib therapy, which can cause edema? There's many reasons why this could be, but yeah, definitely this patient had significant peripheral edema. We also mentioned he had suppressed renin and aldosterone levels, which can be a marker of excess volume, or as we talked about, could be related to his posaconazole therapy. But the patient did have significant evidence of volume overload. And so is he on an appropriate drug regimen? So we talked about it previously. This gentleman is on losartan at a suboptimal dose once daily. He is on an appropriate dose of metoprolol. He's adequately beta blocked, and given his cardiac history, that makes a lot of sense for him to be on that drug. He is on hydrochlorothiazide, or he wasn't taking it actually, but if he was given hydrochlorothiazide, you could argue that maybe chlorthalidone would be better, or given his GFR, a loop diuretic, a long-acting loop diuretic would make more sense. Amlodipine is an excellent drug, but the patient had significant concerns regarding the drug-drug interactions with that. And finally, a weekly Lasix is probably not going to manage his hypertension. Mainly was probably prescribed for the edema. And so for our hypertension management, what we focused on mainly was his adherence. So as we discussed, he was really only taking 2 medications, his losartan and the metoprolol. He was not taking the hydrochlorothiazide or the amlodipine except PRN as well as the Lasix. And so that was one aspect. We also focused on his excess volume. So he had many characteristics of volume overload. He also has chronic kidney disease, and so we think that is due to prior acute kidney injury. Maybe ibrutinib is playing a role. He also has history of coronary disease as well, without diabetes. And so definitely, losartan is an appropriate agent at this time as well. Even though he has suppressed renin, losartan does have some protective effects for the chronic kidney disease. And then finally, we talked about his ibrutinib therapy and posaconazole. Now, we always like to discuss, okay, we should stop or decrease or measure levels of interfering substances. But unfortunately, I can tell you that his posaconazole levels were appropriate. Interestingly, posaconazole also interacts with the ibrutinib and makes the level higher. So actually, his ibrutinib was dose adjusted appropriately. Per the hematology colleagues. And so really, he needs these, unfortunately. So we can't just say, oh, you should stop things that are maybe causing you hypertension, because we don't want his CLL to progress. We don't want him to have aspergillosis. So we need to work around them. Okay. And so what did we do to focus on his adherence? So I focused a lot on patient education. He was a very reasonable gentleman, and we had a long discussion about the pharmacokinetics of the medications. Taking amlodipine PRN really is not going to work, et cetera. And we also talked about the role of volume-mediated hypertension, and he was very appreciative of that. We also had a discussion about mutual decision-making. We talked about, are you willing to try the low-dose amlodipine on a more regular basis, as you have seen that it is very effective for you? And he said, no, I'm not interested in that because it's just too potent. And so we had this, kind of back and forth mutual decision-making based on his blood pressure regimen. We also addressed the self-adjustment of the medications and also arranged for close follow-up with myself and my attendings as well as nurses, just to keep I wanted him to keep me in the loop of what he was doing with his medications and not to adjust them without us discussing it first. And so what we ended up doing for him, and that will bring the discussion of what your thoughts are. Given his chronic kidney disease, given his coronary disease, we decided to continue the losartan and metoprolol, although as previously mentioned, we actually moved losartan to at night, given that he still had nighttime or nocturnal hypertension. And then basically, the only reason I decided to try this was because he already had a prescription for it. So I decided to reintroduce hydrochlorothiazide just to see if this would help with his blood pressure, given that he has evidence of likely volume-mediated hypertension. And so what I can tell you with that, initially his blood pressure was better in the clinic. In follow-up with the nurses about 2 weeks later, he had manual readings in the 130s. Just one reading was up to 142 with acceptable diastolic readings. He had a standing blood pressure of 120/62, and he had very similar home readings as well. We didn't obtain a follow-up 24-hour monitor, but we felt that at least initially these blood pressures were well controlled. So I'd like to bring up the discussion of what you guys think of our thought process and our management at this point. So,
are there any quick comments as we have to bring this case to a close?
Okay.
I would say, generally speaking, RAS intervention and beta blockade is the least effective combination. So some other type of combination should have been tried. It seems fortunate that standard dose of hydrochlorothiazide was helpful in with this low GFR level, but one doesn't argue with reality.
Yeah,
Right.
could I add to this? I think going back to thiazide diuretic in this situation seems to be strange. It might work for a few months, but there will be a problem again. I would go with a loop diuretic at this stage, I think,
Right.
because even if he improved, it would be transient. The disease progresses, I think.
Is your patient still on the azole and the ibrutinib?
Yes, he is. Yeah.
So how come the blood pressure is so well controlled?
Right.
So
right.
I argue against the
Yeah.
drug interactions.
Right.
I think this patient was, to begin with, poorly
taking.
managed from
Right.
the combination standpoint.
Right.
And we heard that the definition of resistant hypertension was
Right.
not met.
Right.
So the regimen was inappropriate. The patient adherence was absolutely poor. So you have a patient on even suboptimal losartan dose, which in my opinion is the weakest ARB, and 50 milligram does nothing, and hydrochlorothiazide 25 short-acting, and metoprolol that none of the nephrologists in the room would use it, is controlling patient's blood pressure. So I have a bit hard time to understand that this was a resistant hypertension and there was a specific drug interaction.
Right.
It certainly seems as though this patient was volume overloaded, but I did just want to make the point that, and you may be aware of this, I think it's underappreciated that when people did radio-labeled albumin studies of patients with essential hypertension, this is like Harriet Dustin, Froelich, Hoffman around 1970, the impression was that it was either normal in essential hypertension or often reduced, occasionally increased. So I think perhaps an underappreciated point that essential hypertension is often a volume-depleted state when assessed in that way, something for us to bear in mind.
Okay, Gary.
I have a question. Is his edema better or worse now that you've changed his medication? Because if we attribute it in the past to amlodipine, he wasn't actually taking that. And once a week loop diuretic seems to be setting him up for cyclical edema and counter-regulatory effects.
Sodium avid state, yeah.
And I wonder whether that was something that was just contrived.
Right. So yeah, I mean, I presented this case as to how it was submitted before, but yeah, like a lot of time has passed since then. And so yes, I wasn't stating that yes, it's the posaconazole or yes, it's the ibrutinib. Certainly it could be playing a role, but yes, the patient's volume status wasn't well managed, and so we started to try the hydrochlorothiazide first. And so, but eventually, yes, this patient did need a loop diuretic, and so yes, we did push the patient on etorsemide, and so that's what we've been using for him.
Thank you. And just in terms of my original question, did his edema go away when you changed?
So not originally, no. So yeah.
You know, in patients that I've treated like this, I have called the infectious disease person and the oncologist. What's the prognosis? How long do they need to be? Lifelong? Because he had, I guess, bulky lymphadenopathy. You didn't tell us what his white count was. But I think we have to decide what our target blood pressure is in a patient with an immunocompromised chronic malignancy that maybe the oncologist wants to use a tyrosine kinase inhibitor indefinitely. And, you know, what is the best therapy for that? Also, with the posaconazole, would he benefit from a little spironolactone? So I think I could be happy with these blood pressures for the rest of his life, but I don't know if we're addressing the posaconazole and or the drug that might be best for the ibrutinib.
Yeah, and so in the studies that, so in ibrutinib, like I said, we don't know exactly the mechanisms as to why it causes hypertension, but definitely, at least in this case, we have excess volume on board. So that's one mechanism of action. Another, if you look at the VEGF inhibitors, which you could argue maybe this has some similar aspects, you know, you could argue that vasodilators would also be a reasonable option to use, such as, you know, calcium channel blockers, right? So amlodipine. And so again, that was actually the first one, other than diuretics for this patient that I brought up, was should we bring back this low-dose amlodipine? And that was kind of what happened with the mutual decision-making with the patient. It's like, well, yes, I understand that, and you explained that to him, but he was not, at least early on, was not interested in that. But those were all considerations I had.
So I agree with Jan that this is a problem of multiple interacting disorders, and it requires interaction with the patient and physician judgment in terms of which is the most important. From a strict hypertension standpoint, according to our most recent guideline, blood pressure is still not controlled, and we have reasonably good evidence in older people with GFRs in this range that the target is below 130/80.
I just need a comment about that. Because there's been a lot of discussion. We tend to talk about blood pressure like it's a dichotomous variable. It's either controlled or it's not controlled. And I completely disagree with that sort of thinking. At the individual patient level, there's a range of control levels, in my view. So a blood pressure that is taken down from 180/110 to 140/90 you've reduced that individual's risk from blood pressure remarkably. Is there still a little risk for that individual on the table? Perhaps, but you've done a lot of good for that patient. And that's where an interaction with the patient and shared decision-making comes into place. This patient, who is 80 years old and has all these other comorbidities, and as you could tell by the presentation, was very nervous about these medicines and how he took them. Might be very comfortable with a blood pressure of 136 over 74. And although it doesn't meet the AHA guidelines for control, it's pretty well controlled. The risk that's left on the table for this patient is quite small. And his other comorbidities are likely to take him out rather than his blood pressure. So just as a point, I would say his blood pressure is controlled to a certain level.
Yes,
I prefer that phraseology.
We need to finish this
I
session.
totally agree with that. I do think there's residual risk from multiple different entities.
Okay, Dr. DaCosta, we have to wrap up now. We've got 1 minute, so if you could just wrap up the case, and with that, we'll thank you, yes?
Yes. Yeah, so again, just kind of what was brought up during the discussion too, what could we do to better improve this patient's blood pressure? We could reintroduce amlodipine, we could consider starting an alpha blocker for this patient's BPH, keeping in mind the interaction with the posaconazole. We could change hydrochlorothiazide to chlorthalidone. We had a lot of options for this patient, or a loop diuretic. And so again, hypertension is a common side effect of ibrutinib therapy. We should review medication interactions that can aid in management of resistant hypertension. And finally, addressing adherence in your patients has the potential to solve many cases of quote-unquote resistant hypertension. I appreciate, again, Dr. Schwartz and Dr. Taylor, our hypertension nurses, and of course the travel grant as well for helping me be here today. So thank you all.
Thank you.
Very good.
Thank you so much.
Thank you.
Thank you very much. And with that, I'd like to thank our 2 speakers, the participation by the audience, and this closes this session. So thank you.